we're gonna be going over UV, so that's our kind of a short little acronym for umbilical vein catheter. You guys now in Emerge actually have your own UV. Good morning, Lisa. Come on in, you can sit anywhere. You have your own actual UV tray in your department now, and then there's 2 more UV trays on the labor and delivery unit. So we're not going to go over all of the NRP pieces and stuff like that, but in the sequence of NRP, I just want to say when you would be considering doing a UV. So basically, you've had a baby who's not spontaneously breathing, you've vented them really well, so you have a good secured vent. So it's either with an ET or an LMA. You've done effective vents that move the chest for at least 30 seconds. That's kind of, and it's backwards of what we do for all other like ACLS and PALS and stuff like that. So you want to have effective ventilation first, that moves the chest for 30 seconds. Then you would have done chest compressions with vents for another 60 seconds, and we still have a heart rate less than 60. So that's when I just want you guys to kind of consider what situation we'd be throwing in an emergency UV. There's stabilization UVs and there's emergency UVs, so we're only going to go over emergency UV for you guys today. We're going to go over it practicing on this baby, and then and going over the meds, how to drop the meds and what have you, and then we're going to go over you guys practicing. So we actually have, so just be mindful that it's real epi and real blood today. So just there is gloves and goggles, so just protect yourself to make sure no one gets a splash or anything like that in the face. So these are real cords. One's from a 34-weeker delivery and one's from a term delivery. So you guys can practice away after in whatever role or capacity you would be in supporting that in Emerge. So yeah, the only other thing I want to go over is just who we would be doing a UV on. So it's a late preterm baby. So basically a 34-week baby or like a late preterm 35 is usually who you would consider doing an IO on. So UV, you can't do IOs on babies who are under 34 weeks. Their bones are too soft and you won't be able to get it in very well, and it will slip out really easy or go through it. So that there is considerations in our hospital, and I'm glad that there's so much interest in everyone learning UVs about where we would do that. So it's basically if you have a 34-weeker or under, IO is not an option if you can't get access. And with epi dosing, we're going to be doing that with a UV, and then I'm going to go over ET dosing as well, which is something that's probably going to go by the wayside, but I will go over that because it's still part of the NRP. But yeah, if you guys, this is really informal, so if you guys want to come up and watch, we're just going to go over the steps of inserting the UV, and we're going to practice with the baby immediately here. We're just going to do it just like we would in real life, and then after that, we're going to take over and we're going to do it on the actual cord. So when you have the baby, the first thing, and we have it over here, is you're going to draw up your epi and flush. So I'll get you guys to practice after, but I just want you guys to see this is the tool, and you guys have one in front of you. You're trying to figure out dosing. And when people first look at this, you can just grab that one beside you so you can follow along. When people look at this, they get kind of overwhelmed because it looks like a lot. NRP now really has broken it down basically just to epi. So we're only going to be doing epinephrine, and then we can talk about volume expansion after. But right now, we're only going to talk about epi. So there's 2 different dosing. So if I'm reading from upside down, on the top is either IV or IO dosing, and it breaks it down really easy for you based on an approximate measurement of baby's weight. So anywhere from a 0.5 all the way to a 4 kilo baby. So you get to kind of do an approximation, and we're pretty lucky that with our Panda recess now, we have a built-in weigh scale. So we can actually get a really accurate rate right off the hop. So you're going to say, okay, let's just say we have a 3 kilo baby, because this is actually quite a large baby. I have a 3 kilo baby. What is my dose going to be? And it makes it really, really easy because it breaks it down into mils. So that's usually what we talk in emergencies, just so we're all on the same wavelength. So if you have a 3 kilo baby, for your first dose of epi, you're going to be giving 0.6 mils of epi, either through the UV or the IO, if that makes sense. And then if you go down to the next column, we have ET dosing. So if you had a 3 kilogram baby, you're going to be giving 3 mils, if you follow it down all the way to the bottom there, of epi through the ET, and we can go over that after, but our focus today was UV. And then there's always the option of volume expansion if there's been any kind of abruption or any kind of insult where you think there's been some sort of like bleeding. Sometimes it's not very obvious either, so you might just have a shocky baby with a low BP and like an extended cap refill, and then that would be your indication that you might have to do volume expansion. And again, that's 10 mils per kilo, usually over 5 to 10 minutes. So right now we're just going to break it down. We're going to drop our epi dosing for a 3 kilo baby. So I know I need 0.6 for my UV or IO dose. And again, IO you don't want to do for a baby under 34 weeks. So I'm just going to show you. So you guys are probably familiar with these guys right here. You guys are all emerge nurses, or I'm not going to go over all the steps, but we've been really fortunate that one of the back orders had a silver lining, and they came out with these. So we actually have, and we're only ever using 1 milligram and 10 mil dose, like concentration. So we have these guys now. Oh, where's my little Lego piece? Sorry, do you mind throwing?
It's in there.
Oh, it is? Sorry, I didn't see it now. Thank you. So it's awesome. So now we have these guys. You're just going to take it off. With babies, we're really mindful because we're putting in a central line of any kind of air, so you get your bubbles out. I probably should have gloves on. It's the real deal. I'm going to spray myself in the face. I'll be talking real fast. And then we always have, when we're drawing it up, we always have our 1 mil one, and then we know that this is going to be for UV or IO dosing. And then we have our 5 mil that can be for ET dosing. And then I always label them UV, UV, and then the next one will be ET dose. Does that make sense? So in a hurry, no one grabs them. And then my dose number 1 I have here, and then I, just like you guys probably do for any kind of code, I draw up subsequent dosing. And there is now a range, which might be different from previous NRPs, that you can go up in your dosing. So our first, and it's on here, I'm not going to go over that too much with you guys, but you would draw up, your first one would be 0.6, and your next one, because obviously we've done 1 dose, the baby hasn't responded, I would go up to the largest dose in that range, which would be 0.9. So it does talk about in the little fine print down here, but we have a baby without a heartbeat, so I would go in the highest dose of that range. So we're going to drop our meds. So again, I'm just going to go over UV or IO today. So it's really easy. You're just going to go down here and you're going to drop 0.6. I usually take a little bit extra and get rid of it. And then you're going to have that here and labeled. And you guys can practice this after at your stations. So you're going to have that and you're going to have it labeled. First dose. And then I usually draw up my next one. You guys can go do that after. And I'm going to drop 3 mils for my ET dose. Just getting it all ready. And then we're going to prime the line. So this is as sterile as you can make it. We're putting in a central line on a baby, but in an emergency situation, it's basically a clean technique. If we're doing it for stabilization, then it's going to be a sterile technique. And we have gowns, we have masks, we have gloves, we have everything to make it as sterile as possible. But right now, we're just going to go over a clean one because in an emerge setting, you guys would just be keeping it as clean as possible. So if you had time to get everything ready, you would have, and you guys have this on your trauma trolley and the mat bin. So you guys have a UV tray that looks like this, and you just open it up, and I just get the instruments ready like the physician's going to grab them. And then you have a little add-on pack here, and you basically can start opening and dumping everything that you're going to see here on that tray, if that makes sense. Today we're just going to keep it as clean as we can. So I would have a mask on for sure, and then this guy fell, and this on, and a surgical gown on, and then she would have the same. Anyway, and then the first thing, so we draw up our meds, and then we're going to flush our catheter. So you guys have practice ones at your stations too. They come in a 3.5 and a 5 size catheter. This is what it looks like. It's just tiny. A 3, you're rarely going to use the 3.5. It's for a baby that's 1,500 grams or under. So like really an extreme prem. So if you have any kind of baby that's not basically over 28 weeks, you're going to be using a size 5 catheter. So you have both in front on your stations just to see what they look like. And I leave it in the little sheath that it's in, just like that. And we have these little extension pieces. We got away from the 3-way stopcock, if anyone's done that in the past, just because this is what people are more familiar with. And you're gonna have your flush, and you're just gonna be mindful of air. And again, this would be very clean. I wouldn't be doing it with like this, but with alcohol swabs and what have you. And you're gonna flush both sides of your extension set. So we just, and then leave it clamped, both sides. Pretend I flushed the other side, and you're gonna leave both sides clamped, and you're gonna have it ready. Just, oops. Oh, this is really stuck. You jam that on. This is my practice stuff, so it gets a little gnarly. Okay. And then you're gonna have it set up just like this, ready to go with your flush on. So now if you can imagine, that's all this is ready to go. And then you're gonna come over to baby. And the first thing you do, and I have the steps up there so you guys, so we draw up our epi and our flush. So this whole thing is flushed, and you make sure that it came out at the end. Did I show you that?
Yeah.
There. You make sure the whole thing's flushed before you start. There we go. And then the next one is you're gonna come in and we're gonna clean. So we only use, with a preterm or term baby, we only use the chlorhexidine without alcohol swabs. So green lollipops is what some people call them. But it's just to make sure, if you've ever seen a baby, there's like pictures that have been circulated of a baby that has like 3rd-degree burns, basically from the alcohol. So you have to be really mindful. Even after everything's settled, we usually go and we wash it all off, just because their skin's so sensitive. So you're gonna come in, and you're gonna come in. So right now, if you have a baby that you're expecting a recess on, you're gonna keep the cord long. We would say keep it long so we don't go short, just so we have a lot to work with. So if you imagine, Linky, maybe we should put on gloves because I did use these.
Oh, yeah.
And I'll hold it with the Kelly.
Okay.
Yeah. We're gonna come in. And you're gonna use your chlorhexidine, and you're gonna clean. We're not doing stabilization, so we're just doing an emergency. You're gonna be cleaning where you're gonna be making your cut, okay? So where that is usually, you want it at 1 to 2 centimeters above the abdomen, like flush with the abdomen. So I'd come in with and I would clean, and this is me or Linky, whoever really has the capacity. We clean. And this is an emerge one, so I'm not going to go over it. If it's a stabilization one, we clean quite extensively. But right now, we're just doing emerge. So the next one you're going to do is you're going to, if you look right here, we're going to drape. So we use fenestrated drape, so that's what's going to be on your add-on. And for stabilization, we'd be doing this. But if you imagine right now, you have someone who's put in an alternate airway, so there's either an ET, baby's intubated, and you have someone doing chest compressions here. So that's why a lot of people in other sites, not a lot, but the practice is changing now, where some people might go IO, just because it's really quick access, and it's away from everything that's going on here. It is a big central line that's literally staring you in the face. So it's good access too, but it's what your comfort level with. But again, if the baby's like 34 weeks, not a late preterm, you don't have IO as an option. So this is just another one. You're gonna come in with your fenestrated drape, and I just go like this, and then we're gonna drape it underneath, just so it gives you a sterile field to work with, okay? And then the next step is you're going to tie. So we have these in your umbilical tie tapes, and I think of it as a safety belt. So it's basically a safety belt. So we're going to put it on just in case it starts oozing or bleeding quite a bit. Do you want to do that piece? I'll switch you. And you want to make sure that you're doing it on the very lower base of the cord, and you're away from the baby, like not on the baby's skin, because you'll cut circulation off there.
Loosely.
Yeah.
So no blood comes out.
Yeah, and we have sterile gloves on, so if it does start to ooze or something's happening, you can always just grab it too and pinch it, or you can tighten it. And you do want it snug, but not so snug that you won't be able to pass the catheter. Does that make sense?
Yeah.
And then the next one is we're going to come in and we're going to cut. So we're going to pretend this, because I have the there. And this would be your role.
Yeah.
Well, it depends on what's happening, but we'll go in.
So when you do the cutting, you just have to make sure that all hands are off. There's a blade coming in, and then you would cut it. I'm not going to cut this one, like 1 to 2 centimeters from the abdominal wall.
So it's a bit more flush.
Yeah.
And it is a decent amount.
I don't know where the short one went.
Oh, it doesn't actually pop out like that.
Sorry. There's a short one.
We had it here this morning.
So it's underneath.
Oh, okay.
Okay, now we've cut it.
So we've cut it, and this looks now like this. And now our Kelly is gone. So that's why it's a 2-person. It is like a 2 to 3-person job. So this will be all removed like that, and this would have still been on there.
And this would have been on it still.
So it's a bit more flush. And then now we're gonna come in, and we have these instruments here, right? Because we can use the tray after, but we're gonna come in, and some of them are really, really easy to see. If you guys come closer, this is really obvious. You're gonna have 2 arteries in almost all of them. Once in a blue moon, you'll get 1 artery, and then you're gonna have a big juicy vein, and the vein's usually at 12 o'clock.
And that one is the thin-walled one. The arteries are the thick-walled ones.
One collapses, like the vein. Yeah. But and you'll see it in yours. So try to identify. And if you're ever there for a healthy birth, like a car delivery that we seem to be having quite a bit of lately, if we have time after, we always do cord gases and say, "Can I have a look at the cord?" And you can just look at the thing at the very tip, and you can be able to pick out your landmarks. But usually the vein is right here at 12 o'clock. So she might come in, and you might dilate it if you need it. But this one's so obvious.
Yeah, this one you can easily see, but sometimes it's really tricky to come in, and you can dilate it a little bit like that with your forceps, or you can use those other little things, and you can bring that closer.
Here, I'll just bring the whole tray over, and then they can see what you would be using.
Yeah, sometimes you can't see properly, and you may need a little bit more help to sort of get it.
And then I would hold here.
And for these ones as well.
Yeah.
This usually works.
And then if I have 2 hands,
she would do that.
I'll hold it.
And then you can clearly see where you have to go in, and then you can just pop it in the big one.
So now if we change, I'll change you hands. Yeah. So now I would pass this to her, and I usually have it still in the sheath, or if I did pass it to her without, I would have wrapped it around my hand so it doesn't go flying around.
Okay.
So now we're going to come here.
Okay, then you just push it in gently in the vein.
And when you're
tiny little bit,
when you're going in, you're gonna go 2 to 3 centimeters beyond the abdominal wall. So you have to count if you have a big juicy cord. You have to count for that first, and then go 2 to 3 centimeters beyond the abdominal wall.
Yeah,
we're doing a low line UV, so we don't want to get it up into like the hepatic vein.
And this thing is marked as well, but it's a little bit small for me to read.
Yeah, usually when you hit about a 5-6 for most babies,
then you know you're in.
And then as soon as you're in, I'll open that. We won't actually push it.
And then you withdraw, and as soon as you hit blood, you will see the blood go in, and then you know you're in the right place.
And just do a really gentle aspiration because it comes quick, and you don't want to take too much volume, especially if it's a prem. So then right now we would have that in.
And then you would do your dose.
There. And you do your epi. There, I'm going to take these off. Sorry.
And then someone has to hold this very securely so it doesn't move until I've secured it. But you're first going to do your dose.
Yeah.
We don't worry about
securing it. This is just a life-saving measure. So right now we know it's flushed. I'm going to come in. I'm not going to actually push it in my baby. I'm going to give my epi rapidly, and then I'm going to follow with at least a 3 ml flush. Okay.
And that's also new, the bigger flash dose.
Yeah, it used to. Yeah, and the dose is double what it used to be.
Yeah.
So then we're going to follow with the 3 ml flush right away, and then just like you guys do, you're going to do a pulse check 60 seconds, and we're still doing chest compressions here. The ET dosing, so I would have that in a 3 ml. Just imagine this is a 3 ml, 3 mils of epi. You would just shoot it in here, and then you're followed, if you imagine we're bagging this baby, with either an ambu-bag or a T-piece resuscitator, and you just follow it with that. The absorption isn't great out of here, so you don't want to, if you've given this dose and the baby's heart rate didn't respond above 60, you don't because usually you want to repeat dosing every 3 to 5 minutes for epi, but you don't wait. This is going to be way better access, so you don't wait. So if you've given this and the baby still doesn't respond, you're not going to wait 3 to 5 minutes for that next dose, because this is what's actually going to probably get that heart rate jacked up.
This is a while you wait dose.
While
you're doing
the
this,
absorption's
you
not
can
great, and I
quickly do
feel
it.
like in the future this is going to be gone. But this, and then the same for IO dosing is exactly the same, and you're going to follow with the 3 ml flush too. Just be really mindful, like our pediatricians before, like with Chris and Kofi, they won't go IO because they've seen them go into like slip out too much, and so they're not that confident in them. You guys are, IO is more something that you're familiar with in an emerge setting. So as long as you're not getting that swelling of the limb, then hopefully we're all good. It's just that you don't always get the marrow back with the flash with the small babies because their bones are so small. Yeah, any questions? Talking too fast. I had too much caffeine this morning. Is it making sense?
We're gonna do
Yeah.
the securing.
Yeah, I was gonna say, Danielle, do you have the sticker? Can we remove the sticker?
Yeah, and I feel like I don't want you guys being too worried about the sticker, because that would be like, I'll go over it at people's stations if they want, but this is like, as far as I would be hopeful in emerge that you guys would have to get, you know what I mean, just getting access and getting the epi dosing in, and like we can go over how we, she'll have to suture it in place first, so she can go over suturing. We use 3/0 silk sutures, and then after she sutures it in place, then I would put the sticker on, so I can show. Do you want to do the
let's do
suturing
it.
piece? Okay.
Okay. So let's just get this one. And you're gonna hold that one to make sure it doesn't go.
Do you want me to go on? Let's switch sides.
Yeah, let's do that.
Your left, right?
Okay, so you just put it in the. I just don't want to. You put it in the Wharton's jelly on the side. Okay. And then you sort of tie your good tie here. And you just make sure that you have equal pieces on both ends, because you're gonna wrap it around like ballet ribbons around the cord.
Is that your ballet ribbons?
Yeah.
That's cute.
And then once you know your 3, you're just gonna go around and around, and you're gonna hold it up. And we are just going to go around. This is the ballet slipper thing.
Ballet slipper. That's cute.
And not too tight.
I would switch hands now and do that, just because I don't want it to be dislodged. In NICUs, they actually do they do high ones, so you'll see it on your first X-ray. You'll see it around the diaphragm, and they'll go almost like up to the outside of the right atrium. In NICUs, like that's where how they use them, like a real central or like a PICC line if you think of where you go. But for us, we only do low line ones at our site. So this is just for emergency medications. Most babies will be covered with AMP and GENT. All babies, if we did a central line, will be covered with AMP and GENT. But before we did give any other meds, we have to make sure it's X-rayed and make sure that placement's okay, so it hasn't migrated into the portal veins, because you can cause a lot of damage with gentamicin and if you're in the wrong spot.
And then you just tie it, and you cut it, and you're done. And then it shouldn't come out.
Yeah. And then I can go over taping if you want.
Yeah, you can do that.
Do you want to cut? Do I have scissors? I think I do, right here. So why I get nervous showing these is because it's a bit overwhelming for people when they see these guys, and this is the hard part. It's not this piece. So this would be more like the labor and delivery nurses would come in and tape it, and it's really just a sticker, but it seems to stress people out quite a bit because it is a bit confusing with the different sayings. But how I do it is I basically just pick which side is the sticky side. So I know this side, if I peel this off, it's going to be the sticky side, and I do sticky side towards the toes. And that's just how I come in, and then there is those little 1 and 2 little pieces that you're going to remove. And I just come in, if you can hold that up for me, and these guys too.
Okay.
And this baby, it doesn't stick to very good. And with any other baby, if once we had time, I would put a hydrocolloid dressing down first to protect their skin, and then I would put this, attach this to it. But again, I feel like this, I just don't want people getting stressed out because the hard part is the access. There, and then we just do a little loop with it, and that's just to bias it like a little bit of slack line in the line. There we go. Oops, sorry. And then these pieces just fold over, just like so. And then we would have a little tegaderm, and we usually just do a little loop.
Cool, yeah.
Just to give us a little more slack. And these, so the one thing we didn't talk about is who we would do these on besides the gestation, but you can, if you guys had a baby, newborn baby come back into emerge, I think Kofi was 8 days. He said you can rehydrate it or re-soak it to give it moisture when it's dried out, and you can still access it if you're having a really hard time getting a peripheral line. Again, some babies it's already fallen off by then, so every baby's a bit individual, and we see that on discharge. Some of them we can take a cord clamp, and sometimes it's moist and we have to leave it. So, but you could still access it on a baby who would come in that you need a access on. Yeah. Is that feeling okay for everyone?